Hi and welcome. Today we're going to be talking to genetic psychiatrist Dr. Jordan Smoller about the boundaries between where personality ends and mental illness begins, and the unexpected biological influences on psychiatric disorders. Always happy to have a session with a psychiatrist, and let's see what happens.
Well, thank you for coming, Jordan.
Thank you so much for inviting.
The idea, I don't know much about how psychiatry and genetics goes together. I of course it's obvious that it does, but I just haven't heard much about that. Like, how as a world are we starting to untangle the relationship between a psychiatric disorder and the underlying genes?
Right. Well, I think it's gone through a number of waves, really. I mean, I think there's been an appreciation for probably centuries that, the way we behave and when we're struggling with our mental health, that there's a sort of combination of nature and nurture, although it wasn't really put that way until about, 150 years ago. But there was no really good way of actually studying that. There were some early studies that seemed to show that various conditions, as they were defined then, run in families. And then there were a series of twin studies that people did. And twin studies allow you to partly tease apart how much of what may be running in families is due to shared, let's say, environment, because families share their environment, not just their genes, and how much might be due to genetic variation. And so in that kind of study, you're comparing identical twins to non-identical twins, and you make a series of assumptions that the world, for example, treats identical twins the same way they would treat non-identical twins as a pair. And so any differences in how similar they are with respect to their, whatever it is you're studying, like psychiatric disorders, you attribute to genetic variation. So those studies had actually established, to the extent that they could, that psychiatric disorders seem to be highly heritable. Heritable meaning that genetic differences among people contribute to who ends up becoming ill. But we didn't really know much more than that. And some people have criticized twin studies and said, well, you're making a lot of assumptions about twin studies. So it really wasn't until the Human Genome Project and a whole variety of other things that have followed from that, where we can actually now look at the DNA variations themselves. And for a while, that didn't really go very far because we didn't have the technology. And importantly, we didn't have big enough studies to really answer the question. In the last decade, that has changed. And so there have been just a flood of discoveries, including going from having no specific DNA variations that people could point to and say, that's clearly associated with risk of a disorder, to now, well over 1,000. And we've learned a bunch of things. And I would say that the big takeaways are all psychiatric conditions that have been studied have a genetic component. None of them is completely, genetic in some way or completely non-genetic overall. Two, that the genetic basis or contributions are not like you might think of with classic genetic disorders like, say, cystic fibrosis or Huntington's disease, where you've got a mutation in a gene and that causes the disorder. It seems to be a combination of lots of little variations that many of us, we all carry some of these. And when they add up beyond a certain threshold, they may contribute to actually showing the disorder, but there may be thousands of those for any given disorder. And then there can be rare mutations that create a higher risk. And there can also be another form of genetic variation called copy number variations, which are basically big chunks of DNA that are duplicated or deleted. And we all have some of those too. But some of them can pretty substantially increase the risk of certain kinds of neuropsychiatric disorders, autism spectrum disorder, schizophrenia, and so on. So we've got this kind of picture now that we just didn't have before.
Now, with a condition like autism, although I imagine it's difficult, you can find an underlying gene that's at work, and in a condition like autism, it begs the question, is that just another form of being human as opposed to an illness? It's like, we're trying to improve something that's not that's not actually a problem. And then I imagine, inheritance with epigenetics makes this even more complicated, because certain things can be, if there's trauma in the parent, it can be passed down through epigenetics. Does that just mean that those genes you're talking about get turned on in some way?
Okay, so both of those things you just raised are really interesting and both controversial questions. So the question about how we define any disorder really is a controversial one, because these things are not, discoveries that we make scientifically, that the line between having a disorder and what we might think of as normal variation is here. And in fact, there really aren't bright lines. And for some disorders, how you even talk about it or define it has a lot of impact. Autism, which was described as such only 70 or 80 years ago, has evolved a lot in the way people think about it and talk about it. And it used to be a quite rare disorder as far as people knew. And now, with each successive sort of report, let's say from the CDC, the estimated prevalence has gone up and up. And a lot of that has to do with expanding the criteria or broadening the criteria. But then there's this more fundamental question of, should you even define a line? And, is there sort of neurodivergence in a way that blends into just traits and that everyone has, and there are sort of degrees of these things. And I think that's true in the sense that, like many other conditions that where we define a disorder, again, there aren't these sort of bright lines. There's a sort of spectrum of human behavior. And to some degree, many of the things that we think of as disorders are also variations of things that are traits that we all share. Now, sometimes those things can become, extremely problematic for people and cause disability. And in the case of autism, severely affected individuals can be severely affected in terms of their language, in terms of their, functioning in a variety of ways. But that is a fascinating issue more generally, I think, of where do we draw the line? And so fascinating to me that I actually wrote a book about it, because it's a question that we face not only kind of intellectually, but clinically, and just in our discourse as people often use terms like, I'm so OCD, or I'm so depressed all the time, or something like that, which means something different in a general conversation, presumably, than it does in a clinical context. And what's interesting is that, at least from my point of view, many of the things that we consider disorders are really variations of the same systems that we evolved to use to solve problems in our everyday existence. Things like, avoiding harm. So our fear systems and the circuits in the brain that are involved in that, we all have them, otherwise we'd be in a lot of trouble. And when those go into overdrive or are triggered in disproportion to what the actual threat is, we sometimes recognize that as an anxiety disorder. And you can see that same thing in many different domains. What that also means is that certain things we wouldn't call a disorder, even if they were very impairing, severe procrastination or something, we don't think of as a mental illness. Or, as I like to say, athletic skills, low athletic skills are not a disorder, thankfully, for me.
Are the boundaries, the definition of mental disorders change? I guess that's what Jesse's asking as well. Are we stretching and changing them? And for example, do you see variations in nature where even in the plant world or in the animal world, where there are these, animals may exhibit some form of autism, and it's just the way it is. It's the way that the nature works. Like, are we rethinking what is a disorder in general?
Yeah. I think we are to some extent. And in fact, I think we need to. The value of the way psychiatry went, and it really only went this way starting around 1980, frankly, when the third edition of the DSM, the Diagnostic and Statistical Manual, is published. And as you may know, that was the foundation for how we now talk about psychiatric disorders. Prior to that, there really weren't a lot of agreed upon criteria, and that caused a lot of difficulties. People would it was a little bit of the Wild West. People might go see somebody and get a disorder diagnosis or, have treatments that other people would just not agree was addressing a problem or that kind of thing. So that sort of revolutionary change in 1980 was to say, okay, we need to at least start with some definitions everybody can agree on. And we're not going to say what the causes of these things are. We're going to make them purely descriptive so that everybody knows when they're, we can agree on the language. We don't have to have the arguments about, was it your early childhood psychosexual development, or was it some kind of biological brain process or something. We're just going to say, to call somebody depressed or having a major depressive episode, you're going to need 2 weeks or more of pervasive depressed mood, loss of interest in things, and then at least a bunch of these other symptoms. And crucially, and this was where psychiatry drew the line, it has to be interfering with your function or causing you major distress. It can't just be that you're sad, but that's actually causing you a problem. And so the value of that was we suddenly could agree on what, to a large extent, wasn't perfect, but there was some reliability in how people made diagnoses. There wasn't necessarily an answer to the validity question, meaning, is that really a thing as we've just described it? And is that how you should best define it? We can just agree on, if you define it that way, we all know what that means now. And we can study it, and we can develop treatments by identifying people, let's say, who have it and who don't, and treating them in different ways and seeing, do these treatments work? But there was an ongoing debate about, well, how did this has got to be an evolutionary iterative process. We've got to tweak it because that can't be right. We didn't just come up with the diagnoses perfectly. And that has created a lot of battles. And so more recently, to address your question, I think people are appreciating that we have to take a step back and start from the bottom up. We really need to understand, how the brain and the mind work. How did our brains evolve? What is the function of these systems of behavior or brain function? And that will give us a little bit more grounding in the validity, that we'll be talking about something that is actually capturing a phenomenon that we can then understand better and maybe do better at developing treatments because we're studying the sort of true causal nature of things.
On the flip side of that, you're studying, big data sets, right? Which is the same as, images on a cave wall, where you're not looking at necessarily at the underlying gene, but you're seeing images that, okay, I've got 1,000 patients who've been diagnosed with this particular thing, and I can tie these things together. How does the study of, how does machine learning and where it's not necessarily tied to a specific gene because we don't have that diagnostic test, how does that all start to tie together to help people feel better, to make them well?
Well, I think that the opportunities with machine learning and artificial intelligence are really fascinating, of course, are relatively new on the scene. And this fits into what, we've been calling precision psychiatry as an idea. And as you know, precision medicine has been something that has sort of taken hold in medicine as a framework for thinking about how we maybe move the ball forward and diagnose disease better. And the idea behind precision medicine is that we approach the diagnosis and treatment and prevention of disease, accounting for the individual differences, the differences among us in our biology, in our lifestyle, and our environmental exposures, as opposed to a sort of one-size-fits-all approach that is often, still the case, of course. So if we, want to develop a treatment, right now, most studies will find a group of folks and maybe randomize them to the active treatment versus, let's say, placebo. And if the active treatment on average works better than placebo, we say this drug works for this condition. But of course, none of us is that average person. We're all unique. And this has now had a lot of successes in fields like cancer and heart disease, where we're using genetics and artificial intelligence in some cases to do better. So what I'm really excited about is the notion of bringing some of that to psychiatry. And one way we've been pursuing that is by making use of big data and machine learning. And to give you an example, the problem of suicide is one that we are very committed to and very concerned about. It is the second leading cause of death among young people in this country. And we have seen about a 35% increase in suicide death, the rate of suicide death in the last couple of decades, even more in young people. And many more people make a suicide attempt each year. And what's sort of heartbreaking is we're not very good at knowing when somebody is at risk. We're not very good at identifying when somebody might need an intervention or might need extra support or help or whatever it is that they need. And in fact, decades of research have shown that clinicians like me don't do that much better than chance at identifying who's really at risk. However, most people who attempt or die by suicide are seen by a healthcare provider in the weeks leading up to it. So we have this opportunity. And one of the things that we've been doing is taking advantage of the fact that we now have a lot of data that we could use to try to move this in a better direction. So just like, companies use artificial intelligence to predict our consumer behavior or what we might like to see in our feeds or in our playlists or whatever. And the way they do that, of course, is that they gather lots of information about people and people's behavior, and they then train algorithms to predict future behavior, what you might want to buy or whatever. Well, if we take that same idea, but apply it to a healthcare setting in a way that might be helping us predict behavior that we, could intervene on, could help people stay well, could avoid suicide attempts, for example, that could be really tremendously useful. And that's what we've been doing now we've been working on this problem for a decade or so. And we've made, I think, a lot of progress. We've developed algorithms that do perform quite well. We've validated them, showed that they're cost effective if they were applied with evidence-based ways of reducing suicide risk. And we've even built an app that can be integrated into the electronic health record at the point of care to try to help clinicians and patients to head off what may be a potentially really serious episode.
What could be the data that's going in there? I think, what are you putting in there so that it can start to read that?
A lot of what we have done so far is using, again, electronic health records. And of course, every time you interact with a clinician or a healthcare system, data or information about that interaction are captured in the electronic health record. And these are, widely used, almost ubiquitously used. And so even as we're sitting here, all kinds of healthcare is happening, and that's creating all kinds of data. What the opportunity there is that you have years potentially of very big data on individuals and their health. And machine learning or artificial intelligence tools can make use of this vast amount of information to entertain many more risk factors or factors than I as a human being could, and then produce an estimate of, let's say, the probability that somebody might make a suicide attempt. There are other kinds of information people are now beginning to look at, including things unconnected to the health system, like social media data or other social or environmental data. In our case, we also supplement it with a self-report measure at the time that somebody is seen. So what that does is give us an immediate snapshot of how people are doing.
Obviously, that kind of work has to be done with an IRB, reviewed at a hospital. But people are very nervous about artificial intelligence, right? So does it present ethical and moral questions that are complicated in this context? I imagine, especially since psychiatrists are so moral, they have such a moral responsibility to the patient. Does it create additional complexity?
It definitely does. It definitely does. And I'll say that this has not been deployed clinically. This is not something that is happening right now. Although some health systems do have a version of this. As you say, the research is done with ethics review oversight. And we, in our research, engage ethicists to work with us. We also held a conference sort of diving into these issues in depth, as many folks have begun to do. But I think we need a lot of thought about when is it appropriate to use big data? How do we think about returning this information or using it in a way that's responsible, not only because people worry about privacy, but another aspect is bias. As you probably know, you can inadvertently train biases into algorithms because what the algorithms are doing is they're using data that existed in the way things were and then predicting the way things will be. But if the way things were have certain biases in them, built into them, that's not what you want. So I think there's a lot of work on the ethical use of AI, and we're certainly very interested and committed to that as well.
On this same topic, I have a sidebar question around predictability for somebody who might commit a mass murder or whatever. That is still, would that person still be somebody who previously might have has some kind of a mental illness? Is that fair to say, or is that just an assumption? And if so, can we start to think about that in the field of psychiatry and using data, right? We don't want any more of these really, school shootings, things like that. Any thought around that?
Well, it's not an area that I've, worked in. It certainly, again, brings up lots of ethical issues and sensitivities about where you would get those data and then how you would use it and what would be the false positive and false negative rates of a tool like that. So our group hasn't, but people have developed algorithms in a research context to see if it's possible to predict violence in some ways. Those are sometimes also the cases where people point to the worry about bias, because sometimes when you're talking about activity that's criminal activity or involves the criminal justice system, there are certain biases that could inadvertently be built into that, and that creates a lot of worry. And there are some examples where those kinds of things have happened. But it also raises, I think, this issue of what's the, you can imagine all the risks. In some ways, you can imagine that you have to be really careful about these things. The goal, of course, is to have something that actually could be life-saving or at least improve people's health. And, we have a little bit of an asymmetric, I think, sensitivity to how we use our information, perhaps. People are now, I think, more conscious of this, but we're always giving our information in ways we probably don't know to companies that are, learning from it. Not particularly for our benefit, except maybe to improve our experience of their product. This is a different thing. This is, how do we do better than what we're doing now in a way that could save lives? But we still have to keep our eye on all of the cautions and ethical potential pitfalls of that, for sure.
One of the places we work is MD Anderson on cancer, right? And, they have samples, a lot of they can't use them, but they have samples. They've been studying cancer for 75 years. And the cancer that we are fighting today is different, right? It's evolved because we've treated it over all this period of time. As we experience these giant societal problems, we hit 9/11, then we have the pandemic, do these giant experiences that we all go through collectively, when we get to the other sides of them as a people, as a world people, are we changed? And does that then change the way the disease presents and looks? Is there an evolution to these conditions?
Yeah, and I think that this is also a question where there are sort of two versions of an answer to that. One is there an evolution to how we think of these conditions and how we define them? And that's certainly true. There has been, clearly there's been an evolution in, say, the DSM, but there's even been an evolution in what we think of as pathological or not, or how we express our distress. And there's some fascinating cross-cultural studies that have pointed to the idea that some of what we have defined now in the West, let's say, or in highly industrialized countries using that framework of the diagnostic manual, was not really recognized in some settings. And then once those kinds of frameworks or ways of perceiving distress or how people express distress become known, they, in some sense, generate a little bit of that by giving people a different idiom in how they express their own distress. So I think we've seen that. Depression, for example, used to be thought of as a very rare condition prior to maybe the 70s or 80s. Maybe not very rare, but it was what people used to call melancholic depression. It was very serious. It was not the very broad kind of concept that we think of today, which kind of merged that version of depression with a more what we would call neurotic and minor depression. And so now it's very common, and we think of our symptoms or when we express our distress in certain terms that I think do change culturally. We also saw in the 80s to the 90s, there was a period, you may remember, of panic about repressed memories and multiple personalities. And I mean, I remember when I was in my training, there was a unit devoted purely to multiple personality disorder. And, people had dozens sometimes of personalities, and it was a very prominent and well-studied thing. And then there was a cultural shift, and some of it sort of spun out into things that didn't even make sense. And that diagnosis officially went away, although it was replaced with another sort of variant of it.
Wait, what's the variant? I'm curious, if that went away, what's the variant?
It's called dissociative identity disorder, which shares some fundamental components of that, but people sort of shifted away from the idea that there was a big epidemic of, that mostly people were recovering memories, and that there was this idea that they were splitting off personalities and so on. And there's obviously trauma and dissociation are things that we still think are very important, but there was a shift basically in how we imagined that to be. Then there's a question of, though, are we actually changed in some way? And you alluded to, for example, epigenetics. Is there something going on in our brains or in our biology that's changing over time? And there, I think we don't know. And it doesn't even have to be at the level of biology. It could be psychological in a sense. I think we are in a particularly fascinating and maybe terrifying period right now, because we have so many massive changes going on at the same time. It's very hard to tease apart what their effects are. But for example, social media, and sort of a cliche at this point, but that is a really transformative impact on the world and how people relate to each other. Even just being connected through the internet globally in a certain way. Then we have, these major cataclysmic events. We talked about 9/11, the global pandemic, obviously, climate change, all of these things that have been dramatically upending people's lives and creating a lot of uncertainty. And then, in the wake of those, we see rising rates of depression and anxiety, especially among young people who are passing through periods of development where they're particularly susceptible to these kinds of shifts. And how that's all going to play out, I don't think we know.
Feeling depressed, it can be treated with a walk in the park. It can be treated with drugs. It can be treated just by going to having somebody to talk to about it. How do you create, a treatment that has all these things that are non-medical and medical? There's all these different ways of thinking about it. How do we get an insight into something like that can be helpful for all people?
Well, I think, at some level, it's research and learning about things that help. But I do think you're right. I think, we have to have a sort of holistic approach to all of these things and not try to reduce them to biology or medicines, or alternatively to some kind of social construction that's maybe not, real or something like that. And it's clear that, for example, certain non-medication treatments can be very helpful. Psychotherapies, of course, are one, and we all know about that. There are certain psychotherapies that have more evidence for their benefit than others. What's fascinating, I think, is, and this has come from research that we've done, but it builds on research many people have done, is that there are a couple of factors that are not really treatments, but that do seem to have a consistent effect on reducing the risk of developing depression, for example, after stress, or maybe even, treating milder forms of depression. And those two things that seem to come up over and over again are, first of all, physical activity, and the second is social connection. And we've now seen this in a lot of studies that our group has done. Not only is there sort of an association, but you can now do studies where you really sort of tease apart, is it likely to be a causal factor in preventing depression? And in those studies, those two things of many others seem to come up over and over. So I've become convinced by that, actually, frankly, in the last few years, that has to be an important component of what people are aware of as part of an overall idea of treatment.
It's interesting just speaking about, where we're going in the future. And so recently the Surgeon General announces loneliness as an important problem that we're all facing. And I think since COVID, the public maybe has more understanding and has now more experience, people, talking about physical conditions. And what do you think about the fact, though, that mental health now is finally on the radar? And how does it, people are really understanding we have a mental health crisis in the world, and particularly in this country. And how is that sort of invigorating, changing the field? Where do you all go as your leaders, and what can we do? Because you're kind of in the spotlight for a moment. So how do we harness this?
Yeah, that's a really good question. I think it's in some ways the silver lining of all those negative things I was talking about, which is that, these difficulties and problems did not suddenly appear in the last few years. They've been going on for a long time. There have been tremendous disparities in access to care. And not suddenly, but maybe through an acceleration of recognition. And the pandemic, I think, had a lot to do with that. It is, as you say, in the spotlight. And there's been a lot of action on the government side, also on private industry. So I think we do have suddenly an opportunity. The world is focused on mental health. And that's because, as we say here in our psychiatry department, no family goes untouched. Everybody has some personal or friend or family connection at this point. Part of the reason for that is things have become more common. Part of it is people are more willing to talk about it. And in some ways, that's a virtuous maybe cycle in which it's so common, the stigma has lessened somewhat, although not enough. So I think it creates the opportunity for more support for research, which to me is key, but also there's a real sense that we need to do something now, that it's not enough simply to make discoveries that might at some point benefit people down the road. We have to focus on implementation, on some of the real world structural difficulties that make it so difficult for people to maintain their mental health and also to get access to care when they need it. And that, to me, could be a major step forward. On the industry side, there's been a flood now of startups and companies that are, very interested in not necessarily drug development, although there's that too, but using digital technologies and, support apps and meditation and mindfulness and even connecting people to care. And I think that's a mixed bag. I think in some ways it's easy to overshoot there and to, the thing I worry about there is a lot of this is done from a tech perspective or a digital technology perspective, which is crucial to obviously doing the work. But if you don't have an understanding of the problem itself and also the buy-in and involvement of people with lived experience and how these things actually are going to play out, it risks creating problems as well. But I do think that some of these things that are now much more accessible can be helpful for people dealing with stress and so on. There's also a little bit of a rush for the psychedelics, another new treatment modality, which has a lot of enthusiasm and some data that are very exciting. And then at the same time, again, a little bit of irrational exuberance, perhaps, that's led people, first of all, to design their own bespoke treatments and not necessarily have medical supervision when it might be appropriate. So it's always a little bit of this double-edged sword. It's great news, and we have to be also mindful that people can go down the wrong road if it's not really done thoughtfully. I do think it's good news. About 20 years ago, the big pharmaceutical companies, which had been very interested in treatments for psychiatric disorders, really kind of stepped away from the whole field and said, you got to figure out a lot more about it for us to invest this much money in developing treatments. And I think now that we have learned more at a biological genetic level of at least some components of some of these serious mental illnesses, for example, that's brought people back somewhat to a willingness to focus on treatment development.
There's only so many molecules that have been approved for the human body. If you identify a gene that is at work in something, I think it's 10 or 12 years and billions of dollars to get to that, to be approved inside a human being. Does that create more complexity to how we might untangle some of these things? I don't know whether there's approval for microdosing and things like that. I don't do that, but I certainly know a lot of people who do that. And I think they're just doing it. I don't think they have any, there's no evidence for any of that, correct?
Correct. I mean, and what are they doing it for is part of the issue. Like, there's, to my knowledge, no, solid evidence for the kind of microdosing and repeated exposure to low doses of psychedelics that people are doing. There's no rigorous evidence yet of what that is going to mean. But B, as I understand it, some people are using it for conditions where psychedelics and also ketamine and its related drugs have some evidence of being quite effective, like depression or post-traumatic stress disorder. But some people are using it for other things, ill-defined things, and that does worry me a bit. One of the things that the genetic research, getting back to where we started, the reason people find that exciting, I think, who are in that field, is not so much that we're going to find the gene. We know we're not going to find the gene for schizophrenia. There is no such thing as the gene. And we may not be able to develop predictors or biomarkers for a little while that are clinically useful, although we don't know yet. But when you discover these genetic variations, and as they accumulate, they begin to coalesce and tell biological stories. And this has already happened in ways that I think are really exciting. That is, we didn't really know that much about how the biology related to these conditions worked. And as people began to do these large genetic studies, suddenly many genetic variations, specific genes were identified as being relevant. And then they start to tell a story about certain pathways in the brain or the biology. And it's things that we never suspected before necessarily. Things like the complement system, which is part of our innate immune system, or glycosylation, which is a biological process that seems to be related to schizophrenia, for example. And what that means is we can now pursue the development of treatments that are grounded in that biology. Part of the reason that these things take so long, and in some ways they're so risky to try to develop, and most of them fail when you're developing a drug treatment, is because you don't necessarily have that foothold on secure biology. And the nice thing about genetics is it's kind of, by definition, almost causal. There aren't things that confound the genome exactly or make us unsure about which came first, the biology or the clinical features. And so it has been shown that if you are studying compounds or developing compounds that started with genetic evidence, they are twice as likely to succeed and get through all of the stages of development because they have that grounding. The other opportunity, though, is repurposing drugs. That is, finding the biology and then realizing, we already have a drug on the market that we know is safe that actually does the same kind of thing. We just published a paper using, again, sort of big data, genetics and brain imaging, and finding, and then looking at all of these mechanisms of action that drugs have, and finding a number of drugs that appear to be relevant perhaps to the treatment of schizophrenia or bipolar disorder, that are drugs that are already in clinical practice. That would shortcut things potentially.
Going back to kind of the first point, how would you take then what you're learning now and just sort of give us an example of precision medicine as it's applied here, so that we can start to imagine this future? Like what is it that we're really talking about? Is it?
Sure. I'll elaborate maybe three of the examples that we kind of touched on. So one of them is the prediction prevention example. So we could have better ways of having individualized risk stratification, as we call it. That is, identifying based on individual needs who might be at risk or might need care like in the setting of suicide. And that could be implemented into care in ways that could allow us in, let's say emergency rooms or in other high-risk settings to intervene early and to know what might work best for this kind of person who's experiencing all the things they're experiencing. We think that that's really important. We're actively pursuing that, as are others. Another is knowing what treatment might work best for somebody. So for example, right now, most of our treatments are, when we either prescribe medication or frankly psychotherapy, a sort of one-size-fits-all trial and error approach. So if somebody comes to see me with depression, there are a few different antidepressants I might think of first line, for example. An SSRI like, Prozac or something, an SNRI like Effexor is one of those, bupropion, which is also known as Wellbutrin, or mirtazapine, also known as Remeron. And the studies that have been done suggest that the likelihood that a patient is going to have a response to one of those is about the same overall on average. So I don't really know ahead of time whether this is going to work for you, but as far as I know, they're all about the same. But I also know they're not really all about the same for you. And so what happens is we start a medicine, we wait maybe 6 to 8 weeks to decide whether it's helping. We hope the side effects aren't too bad. If it's not helping, we either increase the dose or we add another medicine, or maybe we say we're going to give up on this and we'll switch to another one of these. And that can go on for weeks or months. And meanwhile, people are feeling very badly, and they may not even be functioning well. They may not be able to go to work. They may be at risk of self-harm, all these things that we don't want to prolong. And so the idea is, could we know something at the start that could help us make a better choice from the start? So for example, we have, again, recently used artificial intelligence with these big data approaches to develop algorithms to predict which of those 4 kinds of antidepressants is most likely to work for an individual patient based on training the algorithm with data and then applying it to a patient who might come in with a certain history and a certain profile. And that algorithm was correctly predicting about 74% of the time, but also it could say, well, the probability that you might respond to the SSRI is X, to the, Wellbutrin, let's say, is Y. And for any individual, you might have a sense of what would be the best choice right now. That, I think, you can imagine, clinical implementation of that could be very useful if we could, it needs to be further developed, and there are all kinds of caveats, as like we've said before. Another one is actually developing new treatments. And I gave the example of, using genetic findings to look for new clues and then characterizing that biology and developing treatments that target that biology. It's the same principle that's worked in cancer, for example, where the standard has always been, until the last couple of decades, let's say chemotherapy, surgery, radiation, which are pretty crude. You're hoping to kill more cancer cells than healthy cells, to precision treatments that are focused on treating the genetic mutation, let's say, that's driving that particular cancer in that particular person. By analogy, there are findings now emerging from the genetics of psychiatry where we now have a sense of a particular pathway. I mentioned this glycosylation pathway that seems to be involved, and we have clues about how you might change the function of that in a way that would reverse some of the problems if you carried that variation. I think there are no examples of that yet succeeding, but there's a lot of work going on in that area. It's only been possible really in the last few years. So that's partly the hope, that we would actually have new treatments based on something more solid than the kind of serendipity that led to pretty much every treatment we have at this point.
And could you apply prevention down the road, right? The way we do in other fields of medicine, or right? So that you could, if we knew a lot about you and we're able to put all this together, perhaps. Yeah.
That's right. That's right. And, I mentioned these 2 protective factors. We, colleague in our group led a number of studies where we looked at people who had been followed for years. Some of them developed depression, others didn't. In one case, it was using the UK Biobank, which is a very big study, followed 500,000 people over time. We looked at every possible modifiable factor that was collected about information. And we said, which of these is associated with developing depression or not developing depression? And then we used genetic risk scores to say, if you were at high genetic risk for depression, does it matter? We also looked at if you had experienced a lot of trauma, did it matter? And then we did a little bit of a fancy analysis that helps you decide whether this is a causal connection. And once again, out of 105 things, first of all, the thing that was by far the most supported was social connection. We also did a study with colleagues in a sample of military personnel before and after deployment to Afghanistan who had experienced, in many cases, combat trauma. And we also had genetic information, and so we could look at whether people were genetically at risk for depression. And what we found was after returning from combat, those who were genetically at risk had a higher risk of developing depression later. Those who had been exposed to more combat stress had a higher risk. But there was also a measure of what was called unit cohesion. It's a measure of social cohesion in your unit, how much people have your back, how much you trust your supervisors, how much social cohesion there is. And what we found was that high levels of unit cohesion were protective against depression, whether you were at genetically higher risk or at higher risk based on exposure to trauma. And it was almost as though it kind of erased those increased risks.
That's amazing. I was actually going to ask you earlier when you're talking about twins, if you had sent two off to combat and they both experienced the same, explosion or whatever traumatic experience, would they both come back, with post-traumatic stress, express the trauma in the same way? But that's a different question. But this is really amazing what you're saying. This idea of what we might overcome with social connection is probably a huge revelation to people watching this, listening. I mean, that's a lot.
Well, and then the question is, what is social media and social connection digitally doing? Is it good or is it interfering with our usual social connection?
And to that end, how good is a Zoom session? If you're seeing your therapist or your psychiatrist on Zoom, what is the difference between that and being in the room, where whatever, more things will come. I've heard a friend of mine, psychiatrist, he said it's interesting both ways. There's a lot of value both directions. So
I think there is. I mean, it was remarkable. In March of 2020, our department, 5% of our visits were video or virtual visits. And by April, I think it was 95%. And, what that meant, and it's continued to mean in large part, is that people who really didn't have access, or they couldn't have come in. And including people who could have previously come in, but it was hard for them to come in, or there's a lot of other stuff going on in people's lives, could suddenly continue that connection. But, it's not the face-to-face. And for some people, that's more important. For others, it works quite well.
Yeah. Well, Jordan, thank you very much. This fascinating stuff you're working on,
Yeah. We have more questions. We'll save it for another session.
Yeah.
I'd be delighted.
Yeah. Thank you so much. It's wonderful.
Yeah.
Wonderful work you're doing. We really appreciate it.
Thanks to you both.
Okay. Bye, you guys.
Bye.